Our last panel session is on public health teaching across the Lifecourse. And to moderate it, we have John P. Allegrante, editor of Health Education and Behavior, and he's a senior professor at Teachers College and the Mailman School of Public Health at Columbia University. John, where are you?
Thank you very much, Carrie. Good afternoon, everyone. Having heard what I've heard thus far at the conference today, I feel compelled, although I regret, I have to say it, Columbia will not be fielding a Final Four team this year. And in fact, the last time we won a Rose Bowl was 1934. But happily, we have over 80 Nobel Prize laureates among Columbians. So I'm exquisitely conscious of the fact that this is the postprandial moment for many of us. So I'm going to be as quick as I can be in introducing this terrific panel. But I, like others, want to thank Sandro for organizing this. I met Sandro a decade ago, and I think he's a class act. But, you know, there are a lot of people in the room that have helped him. I don't think we've thanked all of the people at Boston University School of Public Health events for all the hospitality, all of the precise organizational work. So let's give them a round of applause as well. This session is going to explore public health teaching across the Lifecourse. And we're going to be talking about, we have fortunately a wonderful panel of people who are clearly expert. We're going to be talking about the master's level preparation, doctoral, DrPH level preparation. We'll be talking about lifelong learning and interprofessional learning, something that's increasingly important in this interdisciplinary world of public health. And I want to let you know that I have asked the panel to, in effect, pledge an oath today. And that oath is to offer perspective, perspicacity, and trenchant analysis for us today, all in 7 minutes, and I am sure they are going to do it. So with that, let me introduce who we have here. You know them by now, and I will take a page out of Matt's playbook and suggest that you take a look at these really stunning biographical sketches that are in the program, and I'll just very briefly introduce each one. Marie Diener-West is the inaugural Helen Abbey and Margaret Merrill Professor of Biostatistics Education and the chair of the Master of Public Health program at the Johns Hopkins University Bloomberg School of Public Health. A faculty member at Hopkins since 1986. She told me she was only 20 when she went there. Her research has focused on the design, conduct, and analysis of multi-center trials, longitudinal studies, including 20 years as the deputy director and lead study statistician of a collaborative ocular melanoma study. She'll be talking about the Masters of Public Health Education work. Eugene, or Gene Declercq, our second speaker, local talent who is professor of community health sciences here at Boston University School of Public Health. Gene's research has examined cesarean sections in the US and overseas and is focused on maternal and infant morbidity associated with low-risk cesareans and with repeat cesareans, as well as the programmatic and policy influences on practice related to childbirth. He's a political scientist, and Gene is assistant dean for the DrPH Education here at Boston, and he serves as chair of the DrPH subcommittee of the Association of Schools of Public Health. He obviously will be talking about DrPH education. Next, we will hear from Joel Lee, who is professor of healthcare administration at the University of Georgia College of Public Health. He's also director of the Doctor of Public Health degree program and associate dean for academic affairs. He has been engaged in the establishment of 2 new schools of public health and has been in the vanguard of thinking about undergraduate and graduate education in public health with an emphasis on education for the Doctor of Public Health degree. And Joel will be talking about lifelong learning. Our final speaker will be Tanya Uden-Holman, who is the Associate Dean for Academic Affairs at the University of Iowa College of Public Health. Dr. Uden-Holman directs the collegiate educational programs, leads accreditation processes, and represents her college nationally in public health education. She chairs the College of Public Health Diversity Committee, which is charged with carrying out the college's strategic objectives for increasing diversity and inclusion. And she'll be talking about interprofessional education. So thank you. Marie?
Well, thank you very much, John, and thank you again to Sandro and to Lisa for this opportunity. So I think that my challenge is not going to be the 7 seconds. My challenge is that this is the last session and that we've actually had an incredible overview of education, and the session before us with non-traditional settings really has set the stage for the session that we're doing on lifespan education, public health education over the lifespan. So, so what I would like to say, and that is, looking at my green here, is that I'm pleased to be able to talk about the MPH and use my green button to advance the slide. So first, I'll talk a little bit about the growth of the MPH degree and how it's changed over time, but also talk a bit about the educational challenges that we're facing, many of which we heard today, and possible strategies for the future. So you saw that Lisa had given a slide in the beginning that showed the growth of the MPH from 1936, when the certificate or a degree was offered by only 10 schools. Not very much growth for a while, but by 2003 there were 32 schools of public health, and in 2017 64 schools, 116 programs, including outside of the U.S. And I think most impressively, too, that in 2016 there were 40,000 MPH applications and more than 8,000 MPH graduates. So certainly an expansion over time. But what we know is, as we have heard before, that the MPH was really a degree that was meant for physicians and other health professionals that were working in health departments and other agencies, but that over time this has changed, and the role of the MPH degree and the changes of those who are taking it and the training that they need has been looked at for the past 30 years, starting with the IOM report indicating that training should be broader and approaching a wider scope of public health. And that was referring to training in things like technology and communications, which we have all incorporated. But then the Lancet report in 2010 also indicated a widening scope of public health that was not just within disciplines, but transdisciplinary health, and looking at a health systems outlook approach as well. And what I think we're seeing now, all of us are seeing, is that the MPH is very interdisciplinary. There has been an increase in dual degree programs, so it's not just with physicians and nurses, but we see dentists and veterinarians and pharmacists, but also now business and social work and journalists and many other types of professionals that are claiming MPH degrees as part of their training. So in order to meet these changing roles of the MPH, we really have seen that there are a number of educational challenges, and we saw even in the last session the distinction between a bachelor's in public health and an MPH and a DrPH, but we saw as well this question about what would happen from the high school to the community college to a bachelor's, MPH, and DrPH. So continuing to think about that distinction and how best to differentiate between the training at these different levels and build upon it over time. We're seeing that providing interdisciplinary training in an increasing number of specialties is important, so the interdivisional training, but also providing the training that we're seeing from the Framing the Futures with concentration areas, multiple concentration areas, but also allowing for customization or generalization of the MPH degree, and providing training in skills and values that have not been historically emphasized. And so we see those with the new CEPH competencies in interprofessional education, systems thinking, others that have not been traditionally taught. And I think as well, we have I would call it really a challenge, but also a responsibility to tailor global MPH training, that we're often thinking of training individuals who come to the U.S. for MPH degrees, but there's training that needs to be done in institutions across the world. So how do we go about meeting these challenges? And there are already some creative educational strategies in the MPH curriculum. We know that over the past few years, there have been lots of examples of integrated core and different multidisciplinary experiences. We've heard this morning about all of the collaborative learning, the practice-based learning that is going on and being developed, the active learning. And we know that there's been a lot of opportunities, too, to reach individuals seeking MPH training that aren't able to come to a full-time program. So the increase in part-time programs that will mainly be through intensive institutes or online education allow individuals who can't, because of challenges with profession or personal life, fulfill a full-time MPH degree. We've also seen, though, open education initiatives. So by this, I mean the MOOCs, the Coursera and edX and other educational initiatives that can help supplement MPH education. But I think we're seeing challenges, too, in which they are now becoming part of MPH education. So that is something that we'll need to deal with in the future. And to mention global MPH training, I really think that MPH training for meeting worldwide challenges is something that many of us try to do with online learning and executive programs, but there are responsibilities to try to develop MPH programs in other countries, and so some have been cooperative degree programs that have been held, that have been sponsored by a U.S. school in tandem with an international school overseas. We also see that there are oftentimes where supporting development of international MPH degree programs can be done. A school may be interested in starting an MPH, and so aid by an existing program can be very helpful. And lastly, I think that there are opportunities to enhance the impact of the MPH degree using some of the resources that have been recently developed. And we talked about the Certified in Public Health exam being one way that can help inform us regarding the actual learning and skills and takeaway that our graduates and public health professionals have gained. The job task force analysis that was done in 2014 is one that says we really need to be teaching the skills that are useful in the workplace, not what we think will be useful in the workplace. And so, in brief, I will summarize by saying I think the MPH of the future will be one that optimizes the approaches to creatively teach in different ways, as we've heard all throughout this day, using different modalities, different strategies, and importantly, sharing these approaches, such as how we are doing this today, sharing methods for valid assessment of competencies and measurements of outcomes, and that hopefully by doing all of this, improving public health education will translate to improving better health for all in the 21st century. So with that, I am out of time, and I thank you, and thank you for listening.
Thank you, Marie. Gene, please.
Oops. Okay. Here we go. All right, thank you. I am going to use PowerPoint slides. I'm incapable of actually communicating anymore without PowerPoint slides. My grandchildren come to me and they ask if they can go to the mall. I prepare a slide deck for them on costs and benefits. One of the great values of this symposium today is I'll now incorporate some video. I'm going to have some TAs who will help me with all of this, and I'm going to structure it as a case study. I'm going to talk about the DrPH. I can only do that for several hours at a time, but thankfully, Tanya and Joel said I could have half their time as well in case I go long. The DrPH has been around for a while. It goes back over 100 years. It's from 1912. The first degrees were awarded back in 1912. And shortly after that, I like the quote, the fact that some of our leading universities are now awarding a degree of Doctor of Public Health after courses of work and study quite different from those required for the degree of Doctor of Medicine. And the early literature was about distinguishing the DrPH from the MD. There was a lively discussion about that in the early 1900s. A number of articles came out talking about what would a good DrPH look like, how do we distinguish it effectively. And then after the 1920s, it all kind of disappears. There's almost no discussion around the DrPH, and it sort of fades from our view as PhDs become the preferred degrees in schools of public health, and that's going to be an issue we'll talk about. But it comes back. And you can see these are the trends, at least since '85, since ASPPH has been putting out the data on it. And you can see in the last 15 years, about 170% increase in the number of DrPH students in the United States, to the point where we have about 1,600 at this juncture. And the question is, why such a big increase? And there's two core reasons to that. And one Marie's already touched on, and that is simply we have more MPH grads, and that becomes the base. They want the next degree. They're wondering what the next degree is. And shockingly, they don't want to be us. They don't want to be faculty. They don't want to be researchers. Most of them don't get an MPH to become researchers. They want to go out in the field and practice. And those people with that MPH want to know, how can I be a more effective practitioner? Is this the steps I need to do to be able to get to that point? Which is great. So that's one piece of it. And the other is us. There's twice as many schools offering DrPHs than in the past. And that's going to drive a piece of it. Actually, the size of programs has not changed, at least in the context of DrPH as much. But the number of schools offering them has changed profoundly. The new CEF requirements may change that a little bit. Some of this had to do with the old CEF requirements. But clearly, we see a doubling in the number of schools in recent years. And almost no change prior to that. Prior to 2000, not much change. Since 2000, dramatic changes in this. So, what are the future challenges to a DrPH education? They come down to essentially one thing. How do we do high-level practice-based education in research institutions? Since most of us are in research institutions, most of the structure within the research institutions is geared to that. The easiest way to capture the challenge here, is simply the fact that six of the 10 schools who are ranked in the top 10 in U.S. News, and by the way, BU is ranked in the top 10. Am I covered? I'm required to do that in every talk I give to note that fact. That only 6 of the 10 schools actually offer a DrPH. 4 of them don't, and feel very comfortable not offering a DrPH. And so the challenge for us is, how do we do this? How do we do a good DrPH education? And I'd say this comes down to about 6 different areas. One is, how do we sustain faculty enthusiasm? There's a lot of reason to work with PhD students for faculty. You have them as research assistants. They can be on your grant. You can cover them with a training grant more readily. That's much more of a challenge for a DrPH student who doesn't want to enter into the sort of indentured servitude that we put our PhD students through of 4 or 5 years of working for us. They want to go back in the field. They're not going to hang around and be our research assistants and then ultimately colleagues. Admitting the right DrPH candidates. I'm envious of the people who can say good GREs, great grades, no felonies. I'm going to accept them into our PhD program. In our case, we're trying to assess who's going to be a good leader. What's a clear-cut estimate of what makes a future leader in public health? And that's what we wrestle with the most. Then we're going to say, we're going to make you field leaders. How do we assess field-based competency? And what's the process for doing that? Now, the whole field is moving more effectively to deal with that, and the DrPH has to catch up with that, because we're asking the question, what at a high level? If you're going to have a practicum, what does that mean at a doctoral level to have people going out in the field? How do we assess them? What's a DrPH competency exam look like? In our case, we set it up as a case. It's worked, I think, very effectively for us. Basically, we give the students a case, a problem, and say, you have to come back in 4 days with a solution to the problem. The problem is based in an area they get to choose. They tell us, I work in Georgia. It's going to be Georgia-based. The problem is distinctly not their specialty. We tell them going in. And what that forces them to do is become more of the generalists that we seek them to be as DrPH leaders. Great PhD programs make fantastic specialists. Great DrPH programs make fantastic generalists. And that's much more difficult for us, given the world that we as faculty in schools of public health are trained as. And then the question of, do we want DrPH as faculty? And the answer around schools around the country is absolutely we do, as long as they can get NIH grants. If they have a K, that'll be really helpful. And do we really want, do they fit into our models of education in schools of public health? And can they, even if they come in, move up the ladder for promotion, tenure and promotion in our respective institutions, given the structure is so heavily weighted towards acquiring grants and doing publishable research in peer-reviewed journals, which may not be the practice-based work that we value. And then finally, how do you finance them? Again, not a lot of training grants out there for DrPH students in the same way. And it's often more difficult to put them on grants for the very practical reason is they're not kids, right? They're not 23, they're 35. And they're taking a period out of their professional lives to come in and get this degree. And they don't necessarily want to go through all of the hassles of being on somebody else's grant and on somebody else's research study. So how does the school structure that? How do they reward them? They look at their PhD colleagues who get better funding often and say, why not us? And I think that's a challenge because the schools themselves don't necessarily have the same flows of income that allow them to do that for DrPH students. Now, why is this all worth it? Because these people are spectacular. They're fantastic to work with. They're committed, they're smart, they've already shown a lifelong commitment to doing the work that we value so highly. And they want to come in and they just want to get better at it, right? You don't get complaining about grades. You get people who say, I want to learn these skills so I can make a bigger difference than I've already been making. What a joy that is for us to work with. But the challenge will be, we've set up schools that don't really focus on that. And so how do we balance that? So I'll end with this, because you're supposed to end with a pretentious quote. It'll be long, however, before the supply of doctors of public health is nearly adequate to the demand. That's from CEA Winslow, one of the first people to get a DrPH among the 97 other degrees he got in 1920. I think that's still true. I think the demand is still there in the field. I think the demand is still there among students. I think the challenge is for us, and looking back at ourselves as to how we structure our educational programs to provide the education they and the field needs. Thank you.
Thank you very much, Gene. Jolie.
Great, thank you. Just press the green button to get it started? Great. Oh, okay, perfect. I feel as though I'm fortunate that this is not a two-day symposium. I would be up all night tonight doing my slides based on the previous presentations. There's been so much good information. Everybody is familiar with who will keep the public healthy, and several people have mentioned it. One of the 6 responsibilities that was noted in that report for schools of public health was to assess lifelong learning in public health workforce. And the recommendation went a step further and recommended development of a framework for lifelong learning. So that's what I'm going to talk about initially. And then I'm going to give you some examples of some of the new technologies that have evolved since that report was developed. So the first question, of course, is what's lifelong learning? Of course, like all topics, there's been a conference to address the topic. And the summary statement was lifelong learning is an acquisition of knowledge, values, skills, and understanding that will be required throughout our lifetimes. More importantly, it's continuous and it never ceases, or hopefully it never ceases. And I think the other characteristic is lifelong learning is focusing much more on job skills than academic credentials. Dr. Benjamin was here earlier this morning. APHA was thinking about this in 1959, and they were using the then innovative technologies of videotape and closed-circuit television, programmed instruction, and telephone conferences. And we've moved a bit beyond that. Here's an example. Philip Candy suggested that there were 4 types of lifelong learning. I think based on the nature of public health, there's probably a 5th model, which is a hybrid of the other 4. So let me share a little bit about each of those with an example. Workplace-based learning, which is much more typical in private, large corporations. The 2005 report from NACCHO suggested that many local health departments lack the infrastructure to ensure competent staff, and they reported that at that time, 38% of all local health departments in the U.S. did not have a budget line item for staff development. So here's an example with infrastructure and scale. The Centers for Disease Control operates CDC University, which has a variety of programs available for their employees on a 24-hour-a-day basis, 7 days a week. But it's much more difficult in a rural health department to address the corporate model of work-based learning. Second model, Marie mentioned National Board of Public Health Examiners. The other piece, which is related to Johns Hopkins, these dour-looking gentlemen, there's only one person in the photograph smiling. That's 1921. The Rockefeller Foundation funded the intensive course for public health officers at Johns Hopkins, and those were the participants. APHA, as part of its annual meeting, the weekend preceding the meeting, has a Learning Institute, which includes continuing education credit for a group of different professions. The National Commission for Health Education Credentialing, which offers the CHES and MCHES awards, has clear policies in regard to maintenance of certification, as does the National Board of Public Health Examiners for the CPH exam. Further formal education. 17% of the population in the PH Wins survey indicated that they had a formal degree in public health. Additional public health academic degrees can certainly be used as career ladders. But I think the most common activity is self-directed learning, that individuals want to go out on their own and pursue additional knowledge. The fifth area, hybrid resources. We have professional associations that are providing multiple approaches from those first four categories. Two that are most intriguing to me, it looks like the U.S. Public Health Training Centers are going to be funded for another cycle, and the Institute for Healthcare Improvement Open School, addressing healthcare quality. So in regard to the technologies, several people have already talked about MOOCs, so I'll just make one comment. This month, Coursera announced that they'll begin offering MPH degrees, one based in the US, one based in London. Micro-learning. We're accustomed to the opportunity to offer courses 3 hours a week for 15 weeks, and at the end of the session you can say, well, pick up next session. Micro-learning is much more compressed. It may even be only minutes of activity that's directed specifically at the needs of an individual. And in addition to that, we're talking about a very technologically literate population which can do micro-learning on their cell phone. Learning management systems. We've talked about Blackboard and Canvas earlier. Those are less appropriate in practice setting. The Public Health Foundation operates the TRAIN program. What's fascinating to me about it is the scale. 820,000 courses completed in a single year. What we're now about to see the establishment of a second practice-related learning management system through the National Network of Public Health Institutes. Whether there will be any interoperability between the two remains to be seen. Digital badges. Anybody have a Fitbit? Fitbit users all know digital badges, because you got a badge saying you've climbed the equivalent of the Eiffel Tower, walked from Boston to Cleveland, or whatever it might be. The only one that I'm aware of presently that addresses digital badging is National Board of Public Health Examiners. This is an example of their badges, which are an alternative to traditional certificates or transcripts. And one of the complaints of people who are certified in public health is there aren't enough badges. So wrapping up, what are the opportunities? What does this mean to us as teachers in public health? We're probably going to have to change the way we approach offering opportunities for our graduates and practitioners in the field. And just tying things together, I think this puts the emphasis on our needs to learn new technologies. So with that, I'll wrap things up.
Thank you very much, Joel. Next presenter, Tanya, please.
Well, it's been a wonderful day. We've had presenters that have covered a range of topics, and so as the last presenter on the last panel, I'll do my best to bring it home in a timely manner, so thank you. Well, I'm going to talk about interprofessional education, and the need for interprofessional education and collaboration is really reaching a critical juncture as we look for strategies to address the challenges of the changing healthcare landscape, including provider shortages, rising healthcare costs, an aging population, comorbidities and mortalities, patient safety, including med errors, and addressing the triple aim. And given the vital role that public health has in addressing these challenges, it's incredibly important that public health students are engaged in interactive learning with other health professionals. The importance of interprofessional education has been recognized for more than 30 years by respected national and international health organizations. In fact, in 1972, the Institute of Medicine report, Educating for the Health Team, discussed the need to redeploy the functions of health professionals in new ways in order to provide effective, efficient, and comprehensive health care. Other reports made similar recommendations. In 2010, the World Health Organization defined IPE as occurring when two or more professions learn about, from, and with each other to enable effective collaboration and improve health outcomes. Integral to the WHO's definition is the view that academic institutions and their faculty must realign their institutional culture, teaching approaches, and environments in order to successfully integrate interprofessional education into their curricula and learning opportunities. Although in the past, IPE was often limited to students taking a class in common, today the focus has really shifted to an emphasis on the importance of interprofessional competencies related to real-world interdisciplinary practice. In 2009, 6 national health professions education associations formed a collaborative to promote interprofessional learning. The associations represented dentistry, nursing, medicine, pharmacy, public health, and osteopathic medicine. And in 2011, they published the core competencies for interprofessional collaborative practice. In 2016, the IPEC board updated the report. There are now 15 institutional members. And one of the goals was to broaden the interprofessional competencies to better achieve the triple aim, with particular reference to population health, which I was incredibly excited about since we're public health. That's what we're all about. So in the interest of time, I'm just going to list the 4 domain areas. I know a lot of you are doing IPE-related work. So for the 4 domain areas, we have values and ethics, obviously very important. The second one is roles and responsibilities. This is one where I think we have the most to be gained. We're still largely misunderstood, both for the public health in general, and then I have MHA students involved in interprofessional education activities, and health administrators are really often very misunderstood. The other 2 are interprofessional communication, which we've talked a lot about today being important, as well as teams and teamwork. And each of these areas have sub-competencies. The core competencies and sub-competencies are important as they provide the foundation for curriculum development. Additionally, the increased emphasis on population health as well as on the promotion of health and the prevention of disease, obviously the hallmarks of public health and what we do, provide additional opportunities for public health students to be involved in IPE initiatives on their campus. So although there obviously are opportunities for public health students, I would just briefly note that there are challenges. Most of us think about the challenges being logistical, but sometimes in IPE activities, there's still a tendency to really focus on clinical cases, that focus on a single patient, which has been at least a frustration of mine. And so I think we still need to work very hard to turn that lens so that they're thinking about things. For example, the determinants of health is a great way to bring public health and prevention into it, but that is still a challenge that I see. So just a few key principles. As schools and programs continue to develop opportunities for public health students to engage in interprofessional learning opportunities, there is no singular right approach. In reviewing the definition of IPE, it's clear that learning opportunities don't always have to involve students from a wide range of disciplines. Sometimes it must just be students from public health with one other discipline. A key aspect is the authenticity of the learning opportunity, where students truly do have a chance to interact and share through the lens of their professions. Additionally, you can't call it IPE if you're just sitting next to each other in a lecture hall. That doesn't work. In the past, that sometimes was counted, but not anymore. They really need to be having some type of meaningful interaction. Additionally, I would argue that IPEC core competencies should be the foundation for the curricula, and that IPE learning opportunities should not be one and done. Schools and programs really do need to provide students with multiple opportunities. Some of them will probably need to be required to ensure that everybody has mastered the competency, but others can be electives or through co-curricular activities. And also, it can be delivered through a variety of mechanisms, online, multiple modalities, and in person. So just a few examples from schools and programs of public health. 3 pedagogical approaches that are well positioned to support IPE include case-based pedagogy, team-based learning, and competency-focused curriculum, all those things that we've talked about today. I would also note that emergency preparedness and response is another topic that brings together a wide range of professions and where public health has a critical role to play. So simulations and tabletop exercises can be developed for health professional students, and they can focus on things like an infectious disease outbreak or natural or man-made disasters. And in fact, the University of Minnesota is one place that I know, among others, that is using this type of model. And finally, co-curricular activities provide important opportunities for public health students to learn about, from, and with one another. So there could be volunteer activities. I know that we have a mobile clinic at my university. I'm sure others of you do as well. And it's a great chance for students from multiple disciplines to come together. Also, I know that more and more universities have student organizations that are coming together to focus on IPE. So in closing, as we envision a future with IPE, these are some of my thoughts. And, we really need a shifting institutional culture that moves from educational silos to really having us work across disciplinary boundaries, making sure that students are well prepared to practice collaboratively, stimulating new scholarship and educational innovation. And I truly do believe that public health students can be successfully incorporated into a range of IPE activities. Furthermore, given the importance of public health in addressing today's healthcare challenges, it's truly imperative that the interprofessional education taking place on our campuses include public health so that other professionals hopefully better understand the knowledge, skills, and abilities that public health students and professionals can contribute towards improving the health of populations. Thank you.
Thank you, Tanya. Thank you very much to all the panelists. Let's open it up. We've got about 7 minutes, I guess, for questions and answers. And I think maybe I'll pose the first question. I'm going to be insightful, spelled with a C, for a moment, and be somewhat provocative and suggest that I've found the burgeoning growth of the DrPH degree stunning. And I'm curious, over time, can we continue to absorb the large numbers of DrPH graduates, given that the traditional employment sectors may face challenges in budgets? Where will the DrPH go, and where will they best be utilized in the future?
I actually have a separate question, which is how will we absorb the PhD students that we're producing? DrPH actually makes up about 16% of the grads. PhD students make up over 70% of the grads, and I think that's actually more of a challenge for us going forward, because we're probably getting close to the limit of number of schools of public health that can employ all of those PhDs. I think the field continues to demand this, and the key to DrPH education is that it's interdisciplinary and cross-cutting, so that when they came up with the competencies for DrPH education, they explicitly excluded discussion of the 5 areas and said, this is about cross-cutting education. And those people can go out and work in a variety of areas. So I don't have any worry about that. I think it'll be easy enough to absorb. I actually worry a little bit more about all those people getting PhDs in public health and where they're going to end up.
Thank you. I do too, actually. Please.
So, one model I think for the DrPH is the part-time DrPH, because, they are older, they're usually in workplaces. If they can have a practicum or a dissertation work that is relevant to their workplace, then there's not the problem of where do they go, because they actually stay where they were, but they are able to advance. So just a different model.
Great. Thank you. So let's open it up for questions, please.
Good afternoon. I'm Maria Bustos. I'm an MPH student here at BU, almost graduating soon in May. And I'm from Colombia, and I came here only to do my MPH. It has been an awesome experience, and I'm very, very sure I will do a DrPH eventually. I want to go back to my country, gain some more years of experience. But to be honest, I don't see myself getting out of that professional life and the life I will go back in my country, because I really feel that like that momentum and that need to be an active actor of change in my country, and like feeling I will stop that to go get a DrPH is not an option. So I have been looking for online courses like Johns Hopkins offers, and not all of the programs in the 10 top schools offer those. So I would like to ask the panel, what are your thoughts on moving forward with increasing the offer of these online or semi-online courses?
Well, actually, only 2 of the top 10 schools offer an online, Hopkins and UNC. And University of Illinois Chicago has a very good one. I think the challenge will be just that. There will be people who can work it out, either local people who can do it on a part-time basis or folks who make that commitment. Our challenge in developing and running DrPH programs is to concentrate them in a way that allows people to take a break. And typically what happens for us is students come here. It's a 48-credit program, which is substantial. They do 3 semesters, and the summer, they do fall, spring, summer they do their practicum, fall again, they finish their coursework, they can take their comps right after that, and then they don't hang around. They go back to wherever they've been working already and develop a practice-based dissertation. So it's not as necessarily as bad a commitment of time. It's still huge for them, and it's a big commitment. It's the other half of the challenge I described before. Can we restructure ourselves as schools of public health to do a better job of practice education? Can we then extend that to online and hybrid programs? I'm honestly not a huge fan of straight online programs, but hybrid programs make a whole lot more sense, because a key element in all of this, when we're selecting our students for the DrPH program, one of the questions is, will they be part of a cohort that can contribute to each other? Can they actually add to the discussion? And the challenge with online programs, and I know the people who do them, and they're very good, but the challenge is how do you develop much of a cohort effect with that, particularly if it's just online.
If I could add something. One of the things that's interesting to me about DrPH education is the fact that in contrast to the PhD, which is imported to the US from Europe, DrPH is now being exported from the US to other nations. Primarily Europe and Southeast Asia. I was talking with Dr. Magana about it yesterday. In Latin America, there's less differentiation, doctora, rather than PhD versus DrPH. But her former institution in Mexico offers a DrPH degree, and there's a DrPH program that's offered in Chile by people who were educated in U.S. institutions and brought the model home with them when they returned. So there seems to be increasing attention internationally to the DrPH as an alternative to traditional academic degrees in public health.
Other questions, please.
Yeah, my name is Romeo, and I'm practicing public health, but a bit farther from here, 13,000 miles away from here. I consider myself in teaching in a non-traditional setting, because it's not a high school, it's not a community college, not a school of medicine, but it is a seminary where I teach public health. And I hear all excellent presentation here, and especially the inclusion diversity part of it. But my question is, when you are in a setting where even if your students are all graduate students, and they're not just young graduates, but really have been in a lot of other places of experience, you still, because of the culture where they are from, I mean, to engage and to be participatory and to be talking a lot is like a sign of disrespect and showing off, and therefore they would not really participate. So in my experience, I have just probably succeeded in kind of engaging only a third of my students. But I know, though, when I get out of the classroom, they talk, but when I'm there, they won't. So how do you address that? Because I want to go back and to be really a better teacher. Any ideas? Thank you.
So I can address that a little bit. I'm actually going to pull from my past life when I did quality improvement training in hospitals. So, I mean, people have, when you bring people together, no matter, certainly, obviously, in your case, culture is making a difference, but you sometimes have to be really creative about how do you get people engaged. So sometimes, even so something as simple as when you do brainstorming, sometimes if we just do brainstorming when we ask people to just say their ideas out loud, some people will be, they'll be quiet. And even if I go around the room in the circle, if you're the last person in the circle, you have a panic attack because everyone else has come up with your ideas. So one strategy that I'll do sometimes just to get people comfortable with each other is I'll use silent brainstorming. So my point is you can use different teaching methods to try and draw people out. So I'll have people do silent brainstorming on whatever topic we're doing. I do this in my MHA class too. And then I'll have them do an affinity diagram where they look at what their common ideas are. So the point is that I completely understand that not everybody's comfortable, so you have to sometimes be really creative. Are they more comfortable if you can put them in a small group and then maybe have share back? Can you do things silently and then have them share? So sometimes I, like I said, pull on the things that I did when I was working in healthcare organizations where you run into similar things. Sometimes in hierarchies, the person who's maybe the housekeeping staff won't be comfortable talking if the CEO's in the room. And I'm like, you know what? In this instance, you're all equal. So you're all going to do silent brainstorming together. And I think even setting some ground rules can be a helpful thing too about how in this setting we're all going to share. So just a few ideas.
Do we have a few more minutes? Yeah. Any other questions? I'd like to pose one other question. Perhaps each one of you could address it. I'm curious about what institutions are doing to respond to the changing nature of our professional preparation, in the sense that if practice-based education is critical, what are we doing at our institutions to ensure that faculty have guidelines for their reappointment, their promotion, and their review that are tied to the kind of practice-based education they should be doing? This is a question that's been raised before. One of the previous IOM reports suggested that higher education had to adjust if we were going to make this a value of public health professional preparation. Joel, do you? Sure. I think Marie's going to start.
Sure. So I think at my institution, what had been recognized is that first teaching was recognized, and so a teaching portfolio was included in the materials prepared for promotion. Now, a practice portfolio, most recently, has been part of it. And in terms of also the CV that's filled out every year, there's a practice section to be filled out. So I think that those efforts can certainly help recognize those contributions.
I think it's a journey we're on. I know my school has not completed that journey yet. I mean, we're trying really hard, especially with we have a very new undergraduate program. It's only in its second year, and we're really trying to make it far more interactive. We've been doing a lot of faculty development workshop. Right now, they're not required attendance, but I think it's really something we need to think about is how do we elevate the importance of that so that we get more folks on board. But it's a journey.
And the students clearly want it, and that's their focus. I co-teach with J.C. Grease, who spoke this morning about practice-based education, and it's sort of reverse learning, as I'm learning from her, because I need to learn more how to do that, and that's worked out really well. But we have to structure something around our appointments and promotion systems so that those people who do practice-based education are actually getting rewarded, and the commitment is too often tenuous. Here we're lucky. Sandro and Lisa are committed to this, but it shouldn't just be based on them. It needs to be a structural part of the university's advancement system. And I think it's a real challenge. I'm not sure it's that simple to simply say we're going to do this at some point without making those structural changes, which will upset people who are accustomed to the older system.
Yeah, I'm in agreement with everyone else that it's an incredible challenge at this stage. I think some institutions are moving to multiple pathways for faculty members, whether it's a clinical title series or another option. The other thing that I've just returned on my way here from the American College of Healthcare Executives Congress in Chicago. A number of the health administration programs there were talking about having an executive in residence. Now that doesn't serve all of the faculty, but it helps meet the needs of the students by having somebody who's retired chief executive officer who maintains office hours and can work with students in regard to career planning or thinking about other options.
Thank you. You know, we've concluded in terms of time, but I just want to say this. You know, our panel promised what? Perspective, perspicacity, and trenchant analysis. I think we got it from them. Let's give them the applause they deserve.